Hello and welcome to another episode, the Pain Podcast. Le Pub Scientifique. My name is Bart van Buchem, and with me, Timmy Beams. In the midst of the summer, another episode. So, without further ado, we're going to talk about pain catastrophizing, which is a big theme in both, let's say, from a clinical perspective, but also literature is quite a bit of debate going on, and by I find it a really dirty term, to be honest. I kind of don't like it. I feel really uncomfortable in using it like literally, but yeah, and we're just gonna have a bit of discussion. So it's just for the outlines for this session, you can expect that we dive and dig a bit into the what is really from the literature, from the by definition, how we can, let's say, operationalize it for the clinical work. Gonna a little dive in the neuroscience of catastrophic thinking and catastrophizing in general. And let's see if we can squeeze and give you some ideas how to communicate. Let's say moving beyond, don't think like that. That phrase is trying to avoid. And as last, probably we can give you some advice on how building a clinical toolkit for with a notion of catastrophizing. So let's jump in, Tim. So catastrophizing or catastrophizing. What will your take on that in terms of the clinical and both scientific terminology?
Yeah, well, you've already said it. It's an awful word, isn't it?
It
It's
is.
sort of
It's
wrapped up in
terrible.
so much. Yeah. Do you know what? As you were saying it, I was just remembering a patient of mine. She said, "I know that people measure like catastrophization or something, but I prefer to call it awfulizing." And I always remember that, and just think it was a really lovely sort of switch round. But I think does a good job of really saying a lot about what catastrophization is measuring here is that we are looking at both the magnification of the experience wrapped up in the emotional expression of what's going on, the rumination, which is a common thing, the thinking about, dwelling on, repeating, etc., and the sense of helplessness that someone is in as well. So yeah, I think yeah, coming back to my patient, flipping it around and saying she was an awfulizing or an awfulizer, I think that's kind of quite a nice way of reframing it, or it certainly was for me. So that's my understanding of it. And yeah, I have in the past, I used to measure the PCS, the pain catastrophization scale with people as a fairly common measure. And obviously you get distinct sort of categories coming from that as well. And, depending on where someone scores, that in essence steers you in a direction, doesn't it? It gives you a sense of where you might work. If you don't measure those discreetly, then certainly within someone's narrative, you get a sense of this as well, don't you? So when you start hearing a story and repetition within a theme, etc., comes out, and I think I stole this from Dave at some point, Dave Butler, but whoever it was, I thank, because they said, imagine if they've said this and they've repeated this theme 2 or 3 times to you in the session, imagine how many times they've said it to themselves, just internally. And I always think about that. And the other thing I think about is the influence of catastrophization on things like attention. And you can immediately see how bringing awareness to something can alter your attentional processing, and through those changes, there could be a fairly understandable link with some of what we see in pain. So the increase in pain perception, the altered endogenous inhibitory mechanisms. So you can sort of see where some of this could play out from a scientific perspective as well.
Yeah, so you're already sort of defining it not as a solely cognitive feature, all right? So this is already starting be a remuneration of all the data comes in, and that somehow got catastrophized or magnified in some way without even within consciousness, if you like.
Yeah.
Although
I think, sorry, I'm jumping in there, but I think that a big flip for me is instead of, the blame that can go into this. Oh, look at you, you keep thinking about it, or you keep repeating it, or you're giving it too much bandwidth or whatever. But there's some merit there to someone having the analytical brain, or that they are the type of person, or in this particular situation, that they're able to come up with multiple alternative possibilities of the problems that could arise, or the difficulties, or the helplessness, and instead of seeing blaming someone for that, sort of flipping that around and going, wow, look at your ability to be able to problem solve. So perhaps that gives us a sense of where we might position ourselves from a therapeutic sense. What are you're coming up with the problems, but what's behind that? So that sense of understanding, of uncertainty, of frustration, of your expectations relating to what's going on, I think could all feed those processes in a totally understandable way as well.
Yeah, so there are a few cases I want to sort of just present here. So when you take an interview, or using questionnaires that are designed to locate catastrophizing or pain-related fear, like the fear avoidance and questionnaire. And I think the roots of these questionnaires are sitting quite close to Geert Krombe and Johan Vlaien's work from Belgium, which did amazing work in this area, and still lots going on. I think I can refer to sessions we've had with Ann Mulders.
Yeah.
Is that correct? Yes. So there's still a lot in it, and we can see that the research is also pointing out like this is still an important thing. If people do have this pain-related fear or catastrophizing, it does help. But what my point would be here, so my patient would generally say, well, I'm not afraid of the pain. I'm not afraid. But when they are in pain, they do behave, or they do have signs and symptoms that you would consider to be like anxiety. So they do get stressed. They get these pins and needles, or numbness in both hands, and they feel heart palpitations, and they start to have all these issues you would consider to be part of an anxiety response. So you have these patients, depending on the moment, whether they are in fear or not. So any thoughts on that? Because I find it always very hard to grasp, because it's such a, you're not always in fear or catastrophizing, because it depends on when and what's going on at that stage.
Yeah.
So is it still helpful then to measure it rather than and give it like this label? Because I think that's probably someone's get a label like you are catastrophizing.
Yeah. Well, it's a good question, actually. I mean, what's the value in labeling anything? But from a scientific point of view, it means that you can measure it. So, but whether you're measuring something that, I mean, coming back, like if you're, I'm thinking about Johan Vlaien and Geert Krombe's original fear avoidance model, because it was a sort of stimulus driven model, wasn't it? So the fear came after the pain, and that sort of distinctly tells you the way that you're then going to interpret what that is. And I don't know, I'd have to go back and see Michael Sullivan's original ideas, but I imagine it might have been a bit like that, where we're coming out and we're starting to use other models to rationalize and understand what might be going on inside someone. So you're sort of describing to me what I would consider an emotive and embodied response, and someone at an unconscious level is they just experience something happening in their body when they interpret it. The best approximation of the interpretation is that I must be anxious or I must be worried or whatever. So but it is difficult, isn't it? Because then you're trying to rationalize something that is incredibly challenging to be able to communicate.
So what will be the neuroscience? I think we can bridge then and then come back to the communication. So how could fear induce, let's say, central sensitization or peripheral sensitization, like a true process in the body that is going to lower the thresholds of the nociceptors? Is there
How could it do that? I mean,
could it do it? Yeah.
got a couple of sort of potential ways of doing that, haven't we? We've got, from a brain network perspective, that flip towards a altered saliency and the effect that has on the descending modulatory pathways all the way down to the level of the peripheral neuron. If we have, a predictive or anticipatory shift based on my expectation that when I do this, I'm going to experience pain, will shift you into a place where your body is going to receive what it's expecting. So, from a sensory point of view. That might be one way of rationalizing what's going on, and that's done at a completely unconscious level, isn't it? Hierarchically, that's done so quickly, so rapidly, and so so far beyond.
Yeah, you can't say it's the thought, right? So it's the thought is only one of the symptoms, I would say, or is it one of the causes?
I guess that then depends on. I don't know. We're going into areas where I don't feel confident enough in my current understanding of them, but the whole sort of system 1, system 2s that.
You can see the field is moving as well. Psychology, like unnoticed, so they do embrace the whole predictive processing and understanding of how awareness and consciousness is sort of evolving over the last decade. But they also have these very, let's say, conditioning models, which implies that this is let's say, a grounded psychology theory based on solely, let's say, thinking models. But it's also connected to neuroscience models nowadays. But it's hard to really understand and prove what's going on in the brain. And what the science says is quite interesting. How does a thought can reduce endogenous pain inhibition, for example? Which is, it's a hard thing to say because you can't measure it. It's just a suggestion, or which is grounded in theory and not quite fully understood, but at least it's something like it's a framework that probably leads to different type of treatments, and that's why you probably start thinking about discussing this with patients. But just one of my patients would say, "Well, I'm not making this up." So I am. So even people who are totally on board with the whole idea. So I'm a catastrophizer. But can I catastrophize, therefore having more pain? I said, can I thinking and then therefore I have pain or more pain? I found that a really interesting and challenging thought, which would be hard to say a fully yes, because I don't think we know that we can think our pain. So I'm just thinking this up, literally. Which is an interesting thought, isn't it, Tim? It's like how probably have to be very cautious with these time, because I think when even people like we're getting, if you the deeper you dive into this neuroscience, the more you think it's like a thing, it's like a machine thing. It's not like, and you can reprogram it, or by not thinking
Yeah,
about it, is it better? Is it? I found it
yeah.
challenging, to be
You're
honest.
you're skirting on what I feel like you're skirting on whether or not behaviorist perspectives are the way forward or whether it's something alternative. And I think that's possibly where,
It is, but it's very helpful
yeah,
because it makes sense, right? It's an easy way. So it's just basically labeling, and therefore you're gonna do exposure therapy. I
yeah,
think O'Sullivan does a great job in doing that, and sometimes it works great on
mm,
behavior. And but if it does change pain, not always. Sometimes
mm.
it does for sure, but the mechanisms are poorly understood in as far as I know, and it's hard to predict. And that's probably brings us to the second thing, where if you're gonna link it to, let's say, more modern science like uncertainty and predictive processing, how would that sound like? How would be the accurate way of putting catastrophizing in a modern contemporary scientific view on pain?
Oh, God, what, from a predictive processing point of view? You're dropping me in here, aren't you? So,
Yeah, yeah, of course. You
I mean,
can
I don't know. I'm thinking
put
on
you on
the
the
hop
spot.
here, but
You're the expert, Tim.
thank you very much. I, at a very basic level, that there is enough credibility in the prediction that there is confidence given to that. So it's heavily weighted towards that being an accurate prediction, and therefore less likely that alternative predictions can play out. So, expecting the worst, for instance. So, you know, essentially, it's a bit like the elephant in the room, isn't it?
Hmm.
You're expecting the worst. That's what you see. That's what you think about, and that's more likely to happen as well. Um, Thinking about the reverse, or thinking about the way through that from a predictive processing, is that it is helpful to notice that that's the way that you're sort of, if you want, programmed, and not to dismiss or discount and to sort of suppress it, but to offer up alternatives. So the alternatives might be, you expected the worst. What really happened? Oh, so let's give some evidence. Let's give some credible evidence that something alternative could and did happen. And you can see where um, things like journaling techniques could actually be quite helpful in those instances. Or we've obviously talked a lot about experiential, so embodied practices. So, asking someone to engage in an activity and reflect on that activity. So the ability to sort of update in real time someone's predictions about what's going to happen, again, could be really powerful. It's not going to suddenly just, change things overnight, but at least it gives alternative evidence. So, the weighting is less heavily towards the worst possible scenario. I would, and I'm keep coming back because I've got a patient in mind. Actually, we're working together at the moment, and he's an amazing analytical thinker. That's his superpower. And we keep talking about his superpower because he has the ability to come up with an endless number of potential problems, which I believe, talking to him it's really helpful for his job.
Mm.
The challenge that we have, and this is the challenge I think often with persistent pain, is because there is a lot of complexity and uncertainty relating to it, that a number of his potential problems are credible. Like, that's a credible thing to think about. Could it be that we find this? Yes, it could be, but there's also a number of other alternatives. And a big part of the why I'm bringing him up is that he's heavily weighted towards, you know, the next possible problem. And what we're actually trying to work on is build the ability to understand alternative possibilities and be okay with a bit of uncertainty as well. Sort of sit with, we don't quite know what's going to happen, and can you be okay with that? But doing it in a sort of fairly gentle way to begin with.
Yeah, so just communication wise then. So typical case of when pain catastrophizing lies on the, let's say it's very clear and obvious that I think my patient would be not even thinking about bending forward and making sure he or she is not even trying, because and then the fears that come out would be typically like very vocal. So I'm not going to do that. That's going to break my back. It's a bad idea. I heard that before. So I think that's the obvious. Then there's the patient that will do it, but you can see they're sweating and they're grunging and trying to, and actually say, well, after the second time, they say, well, I don't think it's a good idea to move on, right? I don't think I should. I've tried it again, and it worked. It didn't work out. And then there's the
So
person.
you've described two people. You've got the authorizer, and then you've got the avoider. Yeah. So they're
Exactly. Yeah.
two
Yeah.
different
Yeah. And
parts.
then probably the third one would be someone who's not really vocaling, so just doing what you're saying, and is basically trying to get through, and then
The
the
endurer.
day after or the week after, since I've done that, I couldn't do anything, which is a tricky one, because is the last one, is that still catastrophizing? Is that possibly a mechanism that relates to catastrophizing,
If it
especially
relates
when
to
there's a delay of the
helplessness
onset?
and magnification, it would do for sure, wouldn't it?
Yeah, there's something in it, right?
Yeah.
Does it, from a physical therapy point of view, or let's say osteo or gyro, do you think that's something that will be a main target for therapy?
Well, you
To
could
cope
if
with
you're
that.
looking at problem-based approaches. You know, looking at the thinking behind the authorizer, the saboteur, the endurer, etc. And you know, it can help, can't it? Like naming those parts of that person. And but but that's one approach. You know, an alternative that we've obviously talked about in detail is about the fact that it's helpful to have a solution-focused approach as well, or to have that as your focus. So then they might have an authorizer, but they might also have the positive thinker and the happy-go-lucky, and so there will be other parts of them that need a bit more bandwidth, and
Yeah.
often it's, you know, those people, those parts of them aren't given the bandwidth, and sometimes they're not given the bandwidth because, again, that credible evidence of danger is still present. You know, there is still, you know, some perceived threat there in some way, shape, or
Yeah.
form, and whether that's uncertainty about what's going on, and
Yeah.
whether things will change over time, or a loss of identity, or a shift in agency, or whatever it is. It can be quite understandable that there is that sort of perception of threat still in the background.
Yeah. So yeah, of course. Yeah. Sometimes I've just from clinical experience, it's sometimes just easier to when these worries can be addressed and people learn how to cope with this worry, and they can basically reframe the let's say the fear or the worry about something goes wrong in the back and this is going to be disaster, towards something, all right, so I know this is a feeling I can cope with. It's not gonna be terribly wrong there, even if it's hurting me a lot. And I see sometimes that can be very helpful because it takes away the stress of the, let's say, the cognitive, the circle of thoughts that would helpful and get people to moving. It doesn't necessarily means that people get less pain, right? And I think the research has been quite consistent there. When you see like big meta-analysis and systematic reviews that done over these type of treatment, when they're focusing on worry and anxiety, then you can see they do well on worry and anxiety, but they still report same amounts or levels of pain, but they are more active in life, which is very helpful to understand can you predict the outcome of your therapy if you focus on these types of issues that people have. Although they may come in with a pain problem, but they end up like, I can cope much better, which is reflected in many randomized clinical trials as well. So it's quite interesting. So getting from there, you mentioned something like journaling. I heard you. I'm not sure you said scaling, but techniques to sort of get the conversation on and about the fear or the anxiety that comes with or even previous on pain. What are
Yeah.
your, where do you feel like easy takeaways for the listeners to address catastrophizing without labeling it as such?
Yeah, yeah. Well, I mean, the first place is somewhere we always go is validation, isn't it? And so, if it sounds challenging, why not communicate that back to that person? This sounds
Mm.
really tough, hard, challenging. And I usually also acknowledge and congratulate them for being able to problem solve and come up with the worst possible scenarios, because what would the alternative be? The alternative would be that you just brazenly go through life, without care or worry, and there is a risk then as well. So I tend to go there first, and then you can, I mean, depending on the person, people that you're working with, um, notice, and point out, bring it to their attention about what might be a part of that, and you can rationalize it in a way, and you can make sense of that over time. Some people like journaling, and some people notice things like the effect that this has on their body. Sorry, that's the building work in the background. And then uh, let's hope that they stop a little bit. Yeah. So journaling isn't for everybody, but there are different ways of journaling as well. And we talked about problem-based and solution-based as well. And if we're trying to bring a part of them out, like the happy-go-lucky, the joyful, the calm, the lover, the whatever it is part that's being suppressed. And, there are journaling techniques that you can use to bring that out as well. Noticing the gifts. We talked about sim hunting with Explain Pain, but I like thinking about gifts and glimmers and hope and calm and joy and happiness. And I spend time working with people there. Yeah, we can do a lot about it, the sort of internal reframe as well, the narrative. I mean, this is my work, but I'm sure everybody has different ways of doing it. But we talk a lot about visualizing and even writing down and spending some time picturing that person who they want to embody and be, and but maybe that's strong, robust. Character that they want to be, and although we've sort of scooted over a little bit, it can be really valuable to understand the potential threats and stressors, and the effect that has on our body. So, if someone has a whole bunch of really challenging stuff going on in their life, that can have and will have an effect on their biology. And there are little things that we can do to recognize those. And then there are little things that we can do to support us through those processes. So the lifestyle type advice. So again, things we've talked about in lots of detail, but sleep,
Yeah.
hygiene, diet, etc., actually have value here.
Yeah, I think related to the work of Lyon and Sullivan and many authors we haven't mentioned here, but what you can see this combination of both like education plus experiential learning. And you can fill in yourself how that could work out nicely, and even, and I think even in a like an exercise, in an exercise type of a context, you could stress the idea of I'm weak. That people learning, well, I'm not that weak. You could handle more than you thought, um, which also consists how to deal with flare-ups, for example, that and reframing that. You put it really nicely how validation in the first place, but also secondly, is trying to um, kind of I would say how you say that from validation doesn't mean that you say, well, this is very bad. You should be very worried about this, and I understand. But I think also having the contrary, trying to flip the charge and basically giving information that they're wrong, but giving this information or this experience that they they have to they have to reprogram in that sense the prediction, and then we come back to we're closing the loop with predictive processing, trying to find proof of less threat and therefore more possibilities perhaps, and curiosity thinking. I love that point when people are starting to sort of bring up things that I want to do, and instead of sticking with the uncomfortableness, the helplessness, starting to be more creative again,
Yeah.
which is a great place to be in your treatment. If makes me happy at least.
That's it.
uh,
And it's going to give them, that bandwidth when there wasn't something else to potentially compete with the catastrophic thinking, the awfulizing, as
it
we talked
is.
about. Bringing things that give joy into their life are great.
Yeah. We mentioned a
And I,
few metaphors. Yeah, which
something
could
I've
be.
been spending quite a long time with people recently over is you can both have your worries, and they can be understandable worries, but at
Mm,
the same time you can also have joy in your life as well. They're not they're not like one or the other. You can have both. So and yeah, understanding and making sense of those fears and those worries can alleviate it to a degree.
totally. Yeah. Well, that's a nice final word. So let me
Can I
summarize.
tell you? Can I tell you
Oh,
one last story? Because I
oh,
keep
yeah. Oh, yeah. Go for it. Yeah,
love
we just
before I can
love it.
finish. Like anybody got some stories about their work with catastrophization, awfulizing, etc. We'd love to hear from you. But I had to speak at a conference after Michael Sullivan, and it was the year that Prince William got married. So whenever that was, it was a while back in South Africa. It was in Stellenbosch, and I was doing the talk immediately after him, and someone's question in the audience was like, "What do you think about explain pain as a treatment?" And he basically rubbished it. And then my talk was pain education and it was like basically a talk about explain pain. And I just remember coming up onto the stage thinking, "Thanks, Michael Sullivan. You like completely belittled what I was just about to talk about." Uh, so,
Oh, that.
yeah, whenever I think of the pain catastrophization scale or catastrophization as just a word, I always also come back to that one memory.
It's such a crazy thing, isn't it? Yeah. Well, everyone has this. If you're presenting, there's always the person you don't want to follow up on.
Yeah,
uh,
particularly when they've just said that as well. Yeah.
well, absolutely. Yeah. That's our own catastrophization. Well, there are ways of what we can see from a clinical work. If you have a colleague, people being referred from or referred to, you might have your thinking of, oh God, how are we going to start up? Where are we going to start? uh, don't mention the C word, right? The catastrophization word. Well, as we know now, so just in summary, right? Catastrophizing is not a flaw. It's but it needs an accurate understanding of definition and how it's been communicated. I think that's very important. I think catastrophizing should be, let's say, the scientific term, and that's where it belongs. And the operational work, the day-to-day clinical work, probably needs something very different. You don't have to mention the word, at least, but we know what it can mean, because it can mean different things. It's a threat signal that makes sense in chronic pain for sure. And just saying, our job's probably not. We shouldn't shut it down, but we should listen, validate, and slowly help shift the story by using all kind of techniques available. And I want you just a reflection question. What's one change you could make in your language or strategy this week? So this is a little bit of a challenge. If you're seeing patients this week, just try it. Let's see if you can make that little language change, so you can at least address it and therefore challenging it. That will be a nice way of starting to get more comfortable with your own catastrophization. And I'm urgently asking you, or telling you, you should go to our platform, have a look. There's some talks with Ann Mulders. We did had some previous talks in podcasts about the same topic, and problem solving, and problem-based solving, and solution-based working, which be highly relevant, especially within our premium membership. You can find all kinds of challenges addressed, as well as in the clinical discussions. You will see our experts and residents do use these techniques all the time. So it's great to learn from others just by watching them telling about it or their stories. Yeah, we're sticking with curiosity, and looking forward to the next episode. Lovely. Right. Thank you for listening. See you soon, Timmy. Bye.